Welcome everyone to Psychiatry and Behavioral Sciences Grand Rounds, February 21st, 2025. I'm Davin Quinn. It's my pleasure to announce our speaker for today, Dr. Poonè Haghani Tehrani, who's an associate professor in our Division of Behavioral Health Consultation Integration. So I'm going to regale you with some of Dr. Tehrani's achievements here. She graduated from Isfahan University of Medical Sciences in Isfahan, Iran, as a general practitioner. In 2014, she completed her residency in psychiatry at the University of New Mexico and has since dedicated her career to serving New Mexico's underserved communities. She has a lifelong passion for public service, teaching, and communication skills. This passion has shaped her career vision of promoting communication and integration through rural clinical service development, education, and scholarly activities. Dr. Haghani Tehrani has formal training in medical education, including curriculum development and leadership in education, as well as in quantitative and qualitative research methodologies. Throughout her career, she has created, revised, and taught several curricula and workshops at UNM School of Medicine and the Department of Psychiatry and Behavioral Sciences. Her efforts include educating medical students on communication in healthcare, designing and conducting workshops on effective feedback, and developing a curriculum on integrated behavioral health. Additionally, she has played a key role in developing clinical services, including integrated psychiatry at UNM Sandoval Regional Medical Center. So it's my pleasure to welcome Dr. Haghani Tehrani, and the floor is yours.
Excellent. Thank you so much. I really appreciate the introduction, Dr. Quinn. And hello, everyone. I'm super excited to be here today to talk to you about one of my favorite topics, which is integrated behavioral health. And so the content of this next hour that we're going to have together is based on a curriculum that I wrote several years ago for second-year psychiatry residents, and it was published just recently. And another thing is that if the focus is going to be mainly models of practice in terms of different models of integrated care. So as you might have already seen, these are the learning objectives. And I give you a heads up that when there is text on my slides, I'm not going to read through them. I'll let you read them at your own pace. So just a few seconds for the learning objectives here. So just to summarize, what I'm going to do is to go through the definition of integrated psychiatry and a little bit of a history behind it. And then we will go through a clinical scenario that would kind of like help us play with different types of models and kind of different ways that integrated psychiatry can look like. The introduction part of this session, if it is something that you already know, I apologize in advance. Based on my experience, I've learned that it's better to keep that portion in, because it's not that we all know the same amount about integrated care. And if you have any questions, you can drop them in the chat. And I also hope that we will have a few minutes at the end for open discussion and question and answers. So let's just start with the definition of integrated behavioral health from the American Psychiatric Association. And when did the efforts that led to the idea of integrated care start? So things started in 1998 when the Institute of Medicine was tasked to look into quality of care in the United States. And so there was a subcommittee formed, a work group formed, and they looked into this very rigorously and from all different aspects. And then they came forward with a report in the year 2000 recommending the need for improvements in patient safety. A year later, in 2001, they came forward with another report, which was called Crossing the Quality Chasm, a New Health System for the 21st Century. What they pointed out in this report was this. So they discovered a chasm between the care that we could have and what was going on at the time in our healthcare. And so I'm going to kind of talk about some of the details related to that in the next few slides. What did they mean when they said quality problems are everywhere? They literally meant everywhere. Preventive care, acute, chronic, across the spectrum of age, all different treatment settings, managed, unmanaged care, somatic and behavioral health. And then they also looked into contributing factors, like why was this such a big problem? They identified several factors, and I'm going to go through some of the most relevant ones in the next couple of slides. So one thing that they discovered was a shift that had happened from needs for acute care to needs for chronic care. So all of a sudden, the population had evolved to need more chronic care. And then another thing that they discovered was that about 40% of people with chronic diseases, they had comorbid disease. And this was happening in the context of a fragmented system. So in other words, there have been a lot of advancements in terms of knowledge and technology in medicine, but the administration aspect of the system had not kept up with that. So that was causing a lot of duplications and delays in care. So Clinic A and Clinic B not really communicating together and repeating medical workup and repeating services, or because there was not good ways to coordinate care, referrals were delayed and there were long waits and all of that. And then another factor that they discovered was errors. And these errors were happening due to misuse, underuse, and overuse of services due to, interestingly, lack of adherence to evidence. So we were not doing a great job of adhering to evidence-based medicine. Errors were happening, and then part of our resources were being spent on fixing the negative outcome of those errors, if it was possible to fix them. And, because in some situations, death happens, or, there are some consequences that cannot be easily fixed. So these are some of what that subgroup in the Institute of Medicine discovered and included in their report in 2001. They also noted lack of resources. So reduction in third-party payment, shortage of nursing staff, and lack of access to healthcare insurance. And so people who didn't have access to healthcare insurance, they were bound to wait until they were in crisis in order to get help. So they didn't have access to ongoing chronic care. So based on everything that they discovered, they came forward with recommendations. And this was what they recommended. They said we have to move our healthcare to a care that is safer, reliable, responsive, integrated, available, and across the full array of preventive, acute, and chronic services. And when you look at that report, they have a list of these specific characteristics that they thought healthcare has to adhere to moving forward: safe, effective, patient-centered, timely, efficient, and equitable. And as you all most likely know, the language related to patient-centered with a lot of movements in terms of holistic approach to care and also shared decision-making in patients' autonomy. So this language from patient-centered has shifted to being person-centered, but back in the time in that report, it was patient-centered is what was included. So this is the system that they envisioned, that committee envisioned for the 21st century. In other words, they said we have to move toward a system of care that is evidence-based, patient-centered, and systems-oriented. And basically what they made very clear in that report was that we needed to redesign the system as a whole. So in summary, when we have a highly fragmented system where there is duplications of services in wait times and delays in care, trying to serve people, more than 40% of whom have comorbid conditions, then we do need to have very sophisticated mechanisms to communicate and coordinate care. And that included reliance on information technology. And then also eventually IHI came forward with suggesting triple aim healthcare. And so in triple aim healthcare, basically the focus is experience of care, which is from the customers or the consumers or the client's perspective, the patient's perspective in terms of quality of care, access to care, satisfaction to care, all sorts of different aspects of care from the patient's perspective. Cost of care and population health. And for some of you who may not be familiar with this term, population health refers to being proactive in terms of providing care to our patients. So instead of waiting for people to be in crisis and reach out to us for help, we actually constantly monitor our patient populations, and we reach out to them when we feel they need services and interventions. And that could be as simple as monitoring people's A1C, blood pressure, depression, suicidal ideations, and things like that. So when that 2001 report came out, then people from mental health and substance use side of healthcare came forward and asked, what about us? Does this all apply to us too? Which I personally find pretty fascinating because that speaks to how the mental health and substance use parts of healthcare were siloed from the rest of the system, that they even had to wonder about that question. So before we get to what that committee, the Institute of Medicine committee, did about answering this question, I'm going to share some statistics and information with you. So I'm going to let you read. So as you can see, there is quite a bit of a gap between the need, or like the demand, and what was actually what people actually were receiving in terms of care. And so why is that? Like what has been the obstacle? Like what are the obstacles to or barriers to people receiving mental health and substance use services? So these are some of what have kind of come out of the research and the digging in that area. So as we all have experienced and continue to experience, shortage of providers, treatment cost, not knowing where to find treatment, lack of perceived need due to either lack of education or in certain psychiatric conditions, such as schizophrenia, lack of insight, stigma. So these are some of the barriers that have been identified. Another piece of information that I wanted to share with you is what I found out in the, I found this piece of information in the literature in 2017. And I am highlighting that because things have changed quite a bit ever since then. So let me show you what is on here and then explain to you what has changed. So based on NIH reports back in 2017, when I was looking into all of this, 75% of patients with depression, they sought help from their primary care providers. Only half were accurately diagnosed. And then the ones who were referred, only about half of them made it to the consultant. And so this has changed because ever since then, there have been some requirements added to the ACGME guidelines for family medicine residents. So familiarity or training in mental health and substance use disorders have been added. And then more recently, I believe as of last year, also another requirement that was added was to become familiar with integrated care. But this basically was at the root of those steps. So with all of that, basically that same committee under the Institute of Medicine, interestingly, they spent several more years. And in 2006, they came forward with a report specific to mental health and substance use conditions. And this is what they said in their report. They said the same recommendations apply to mental health and substance use conditions. However, they found that some of the gaps within the system were larger in the mental health and substance use conditions. And so based on their findings, they said in addition to evidence-based, person-centered, and systems-oriented care, in these other areas also we need more work. One of them is quality measurement, both at individual patient levels in terms of outcome of care for every individual patient in terms of monitoring and tracking symptoms, as well as quality measures at more institutional level or provider level. They also noticed that there were larger gaps in the infrastructure within the mental health and substance use conditions. And that starts with evidence as well as diagnostic and assessment strategies. And they said ultimately their recommendation was to integrate behavioral health and substance use disorders with one another and also within primary care. So when they came forward with these recommendations, and there are a lot of specifics related to that in their report, people took this. They took it and they started experimenting with it and coming up with different ways of integrating behavioral health and substance use care into primary care. And they started collecting data, evidence, and writing it up. And this is what they came up with in terms of, or what they found out in terms of the advantages of integrated behavioral health. So I'm going to let you read them. And so interestingly, as you see, most of these are very consistent with that IHI triple aim care model. And then this has actually now over time evolved to being quadruple aim care. And the fourth piece is provider satisfaction and well-being. And so evidence has shown that that provider satisfaction and well-being also impacts quality of care. And as you can see, the evidence on integrated behavioral health has also shown improvement in provider satisfaction. And that is both with the behavioral health provider and the primary care providers. So as people were kind of like working on this and experimenting with all sorts of different ways of integrating behavioral health into primary care, then things started to feel kind of scattered. Like when I was looking into the literature in 2017, it was very confusing. Like people were using the same terminology, describing different things, or using different terminology, talking about the same thing. And so eventually SAMHSA came forward with a categorization of integrated care, which has been really helpful in terms of bringing some consistency and unification in the language, although there is a little problem with it, which I will talk to you about a little later. But I'm going to show you what they came up with. This is pretty wordy, so I'll give you a couple of seconds to take a quick look at it. And then I want to draw your attention to the fact that in coordinated care, there is a referral linkage. So an example of it would be that I'm a psychiatrist or I'm a primary care provider here at SRMC. And there is, for example, this Rosewater Clinic out in Rio Rancho, and they have psychiatric care, and I refer my patients to them for psychiatric care. And we may or may not do regular communication in terms of coordination of care. In co-located care, there is also a referral process in place. And in integrated care, it bypasses all of that. It bypasses the need for having some sort of a linkage or process in place for referrals. And so we're going to talk about how that looks like. So from here, let's just kind of play around with a clinical scenario. And I would like your engagement and participation. So you are going to shadow Dr. A in a family practice clinic. And Dr. A, and you will be spending 2 days with Dr. A, and Dr. A asks you that by the end of day 2 to answer this question: which models of primary care behavioral health is or are being practiced at this family practice clinic, and why? So I'm going to walk you through the observations that you're going to make in the next couple of days, and then see what would be the answer to this question. So one of the things that you noticed happening was that Dr. A received a message through the electronic medical record from one of the primary care providers saying that, hey, you know, this is a patient that I've had, this is their age, their medical conditions, this is what's going on with them in terms of their behavioral health, and give me some recommendations in terms of what to do next. So this is one component of integrated care. And oh, I'm kind of going ahead of myself. So Dr. A is in the same clinic space, using the same exam rooms and using the same electronic medical record. And then they received that message that I just told you about. And so that is an example of an e-consult or electronic consult. So that's one thing that you noticed. And then another thing that you noticed is that Dr. B, as Dr. A is in the workstation and they share the same workstation, so they are all in the same space. And Dr. B is one of the primary care providers. And as Dr. A is kind of like sitting in front of their computer, working on patient care matters. Then Dr. B turns to Dr. A and is like, hey, I've had this patient and, this is what I've been doing for treatment of their depression. This is where we are. And I'm wondering what would be the next best step. And then Dr. A gives recommendations. It also works the other way around. So I have been in situations where I was like, hey, Dr. So-and-so, I just saw one of your patients and I want to start them on modafinil and their blood pressure is kind of high. What should I do? And then Dr. So-and-so was like, oh, do these labs and then start this medication and increase the dose at this pace. And then in so many weeks, repeat the labs and then you can increase more. And so anyway, I was able to manage the patient's blood pressure and get them started on modafinil without having to wait for them to see their primary care provider. And so this is a curbside consult and another component of integrated care. Then you noticed another thing that happened. As Dr. A was kind of hanging out in the workstation, Dr. C walked up to Dr. A and said, hey, Dr. A, do you have a minute? I just saw one of my patients who was scheduled for management of their blood pressure. And I'm really having a hard time controlling their blood pressure. And one thing that I've noticed is that they also have a lot of anxiety and insomnia because of that anxiety. And I think we really should do something about that anxiety, insomnia as part of controlling their blood pressure. So then what happens here is that you all with Dr. C walk to that same exam room where Dr. C had seen the patient, and Dr. C makes introductions, and then Dr. A spends about 25 minutes evaluating the patient, giving recommendations, starting treatment, and sending the patient their way. And as part of this, also Dr. A can offer follow-up appointments. So can see the patient for follow-ups to make sure that the patients, for example, anxiety and insomnia in this case, were effectively addressed. So this is an example of a warm handoff. And this would happen only within this context. With curbside consults and e-consults, the provider, the behavioral health provider, doesn't really have to be stationed in a primary care clinic, but with warm handoffs, we would. And this is what takes access to care to another level. Another thing that you notice happening is that there's a patient who has had problems with depression, and then a few weeks ago, they lost their job. They are so stressed out, terrible anxiety, their depression is worse. They now have suicidal ideations and a lot of financial stressors. And so what you notice Dr. A doing is that Dr. A recruits the social worker and the clinic nurse, and the social worker works with the patient on accessing resources in terms of food and other resources in the community. And the social work and the nurse team up to kind of call the patient every other day to check on the patient and make sure that the patient is not getting worse. And then Dr. A and primary care coordinate to kind of like see the patient more frequently between the two of them in the next few weeks, so that as a team, they can help the patient out of crisis. And so this is an example of team-based care and also biopsychosocial approach to care that is really enhanced in the integrated care setting. So now, based on everything that I shared with you, we have like Dr. A in the same physical space as the primary care providers, using the same electronic medical record system, having access to team-based care and biopsychosocial approach to care. Which model of care do you think this is, looking at this illustration per SAMHSA? And you can either just unmute or type in the chat. Integrated care. Cool. Yeah, exactly. So this is an example of integrated care model. And one thing that I wanted to point it out here is that in an integrated care model, we could utilize a database to track patients in terms of their symptoms. What I just presented did not include that, but later on, I will talk about a specific model that uses a database to track patient symptoms. Okay, so now let's add, oh, and then another thing that I wanted to also mention is that there are challenges with this model. And so one thing that I wanted to point out is that when we talk about integration of care, care has a lot of different aspects. So it's not kind of like just a one way of like you integrate these two things. There you have patients, you have physical space, there are support staff, there are other healthcare workers such as social workers, and then there is budgeting and funding. And so these different aspects, each of them can be integrated or not integrated.
Oh,
And also they can be integrated.
Benoit's note. Yeah. So that means that he's kind of like absorbed by
Hi,
acute.
Dr. Jink. Sorry, thank you.
No worries. Okay. So yeah, so each of these aspects of care can be integrated or not. And then if they are integrated, they can be integrated to a different extent. And then, then it can also pose challenges based on coding and billing and reimbursement. For example, if the budgeting and funding aspect of care is not integrated, which is kind of like the situation that I'm in, because I'm hired through Department of Psychiatry, but I work at the family medicine clinic at SRMC, and the providers in my clinic, some of them are hired through family medicine department, and some of them are hired through medical group. So if they consult me, they can document that and get reimbursed for my services. If I was hired, if we were all hired through the same entity, then it didn't matter because the entity would get reimbursed for my services. But that's not happening. And I have to make sure that I generate revenue for whoever is paying my salary. That's like my Department of Psychiatry. So these are some of kind of like the challenges that are inherent to this model. But then at the same time, the model is so flexible that makes it easy to, in creative ways, kind of get around some of these and overcome some of these challenges. So with all of that information, now I'm going to give you some more information. So you are having some additional observations shadowing Dr. A. So in the afternoon, you notice that Dr. A.
Thank you so much. Bye-bye.
Dr. Jean looks like, okay. So in the afternoon, what you notice is that Dr. A gets stationed in one of those exam rooms in the primary care clinic and starts seeing a few patients back to back. And then with one of those patients, Dr. A tells the patient that, hey, it's been 3 months that your depression is in remission. You're doing really well. And we can refer you back to your primary care provider. How do you feel about it? And the patient is okay with it. So Dr. A goes ahead and sends a message to the primary care provider, communicating to them that, hey, this patient is doing really well. Do you feel comfortable taking over their care? And then through this process, the patient gets transferred back to their primary care provider. So now with this additional information, what model of care do you think this is? Very good. Yes. So this is co-located care. So in co-located care, it can either look like what we have at HSC, at the Health Science Center, like with the mental health center being a building in the same property of UNM Health Sciences. And then we have the UNM hospital, and there is exchange of patients in between the two buildings in a sense. And so they are part of the same entity on the same property. It could be like that, you know, I'm at SRMC and I'm on the second floor, sitting in my own office, and then the primary care providers, they identify the patients who need my help. We have some sort of a referral process in place. They refer patients to me. I see those patients at my own time. Then, you know, we can kind of communicate through electronic medical record if we run to one another in the hallway. Or it can be like what I just described, that, you know, the behavioral health provider is actually in the same space as the primary care providers. So what I have described to you so far is a hybrid of an integrated care and co-located care. Basically, what is significant about co-located care, similar to coordinated care, is that there has to be some sort of a process in place for referral. So now let's talk a little about collaborative care model. So collaborative care model is kind of like the Mercedes-Benz of integrated care. It has very strong evidence in support of it. It's very well established. It has a very clear-cut model of operation and very clear principles. And so I want to kind of walk you through this model a little bit. So in this model, as you can see, the psychiatrist has a dotted relationship with the PCP and a dotted relationship with the patient, meaning that based on this model, the psychiatrist is really not required to have direct interactions with these two people. And the care manager is the person who plays a key role in this model. So the way it works is that the primary care provider, when they identify a patient who needs help, they contact the care manager. The care manager does the screening and the intake of the patient, and then they contact the psychiatrist to get the psychiatrist involved in terms of getting recommendations. The care manager can be a psychologist, a social worker, or a nurse. Their level, like their degree, is not specified in the model. More recently, there have been some studies done on having a nurse practitioner in this role. And they actually have had some really positive outcomes. So what they are talking about is that basically a nurse practitioner, what they bring in terms of their nursing and their nursing knowledge and skills into this model has been really helpful in enhancing care. And also when psychiatrists makes recommendations in terms of medications, then that nurse practitioner would be able to move forward with writing the prescriptions. So it can kind of like facilitate the care and bridge the need for communication between the psychiatrist and primary care provider. And that's with kind of like the idea that not in every state nurse practitioners are able to practice medicine independently. And so in some states, they do need to be supervised by an MD. Okay, so let's kind of like go into more details of what the care manager does, which makes this model very unique. So the care manager manages this thing that is called a care registry. And so this care registry is kind of, as you can see, is kind of like an Excel sheet of all the patients that are under the care of the care manager for behavioral health services. And so the care registry, there are versions of it out there that can be embedded in the electronic medical record. And at UNM, we actually have one. Several years ago, one was purchased. We are not using it optimally. So there is there is room to kind of for improvement there, into kind of make sure that we take advantage of this resource within our system. But what happens is that the care manager, every time they make a contact with a patient, they document that in this care registry. And so care managers are also trained to do some psychotherapy, such as problem-solving therapy, behavioral activation, motivational interviewing, and things like that. So they can have in-person visits with patients, they can have phone contact with patients. For example, if this is a care registry for depression, then they would be doing PHQ-9 either in person or on the phone and documenting it here. So they basically have a global view of every individual patient's care and needs. Once a week, they sit together with the psychiatrist and go over this care registry. And so they look and they're like, okay, we see the PHQ-9 scores here, and great. So these patients, they are kind of like really moving in the right track and reaching remission. If they notice patients that have plateaued or their PHQ-9 score is increasing, then they take a deeper look and in terms of like what's being done, what's going on with the patient. The care manager gives more information to the psychiatrist, and the psychiatrist make recommendations in terms of interventions moving forward. If that includes medications, then the psychiatrist drops a brief note for the primary care provider to see it and be able to implement the recommendations. So as you can see, what is really specific to this model is this population health aspect of care that is incorporated in this model, because we're not waiting for people to be in crisis and come to see us. We are kind of like regularly monitoring them and tracking them and implementing intervention when they need it. So principles of collaborative care model is that it's patient-centered or person-centered, team-based care, population-based care, measurement-based treatment to target. So measurement-based is, for example, use of PHQ-9, which is kind of like something that was in that 2006 report from the Institute of Medicine that, hey, you know, you gotta kind of like do something in this area. And treatment to target means that, you know, I'm going to track your symptoms using a PHQ-9, and the goal is to reach a score below 10 or below 5. It's evidence-based care, and it is accountable care. And by accountable, it means that providers are accountable for and reimbursed for quality of care. So it's value-based care as opposed to volume of care. So on this spectrum of integration, collaborative care model falls under integrated care, and it's actually on the higher side of the integration. So it's one of the most, it's considered to be one of the most integrated forms of integrated care, considering that this all is on a spectrum. One thing that I see as a challenge, and it is other people have talked about it, and I also mentioned it in my publication, The challenge that makes it confusing, especially when you're talking to learners and within the behavioral health community, is the fact that even though these are all on the same spectrum of on the spectrum of integration, this is called integrated care, because coordinated care and co-located care are also like lower levels of integration and forms of integrated care. And so that is kind of like one of the critiques of this classification. But then at the same time, like I said, it has had a lot of advantages and helped quite a lot. Okay. So now with all of this, I have a couple of other slides, but I saved them for only if we have time. Let me open it up to questions.
Dr. Haghani Tehrani, is it all right if I start off with a question?
Yes.
Thank you. So you mentioned sort of the use of a registry, and that we actually have one here in our EHR, but that maybe we're not taking advantage of it. And was the screenshot that you shared actually from the tool in our EHR?
No.
It's not?
No. That's kind of like just one like example that's was shared in some of the training.
If that's something that we're interested in doing, because I could actually imagine that, for instance, for our TMS service, where we're working a lot with sort of other providers, we're doing measurement-based care, we want to kind of track people over time and be recording a lot of data and different members of our team. How can I get trained in how to use that tool? Is that possible?
Yeah, absolutely. And so I think I'm trying to remember who it was, because within the UNMH leadership, there are people who are aware that we have this tool and we're not optimally using it. And so I think if we want to use it, we can just get access to it and start using it. And so it's just, and it's partly also is helpful with collecting data in terms of metrics and all of that. So yeah, I think certain things need to be kind of set up within the system. And a lot of like the major things that we would need in terms of behavioral health care, from what I understand, are actually already set up within this care registry. So it's just a matter of being aware that it existed, which is part of why I brought it up during this presentation, and start utilizing it. And as we go, we can optimize it. So I can put you in contact. I forget, he is kind of like one of the doctors in higher up leadership at UNMH. I can kind of coordinate contacts so that we can, support your team.
Thank you.
Sure.
Yeah, maybe it's Dr. Christensen. We'll bother him first. All right.
It's not him, but Dr. Christensen is in contact with that doctor that I'm forgetting his last name. So yeah, but Dr. Christensen would be a good person to reach out to.
Thank you.
Sure. Okay. What other questions?
Dr. McQuarrie has her hand up.
Oh yes, please go ahead.
Very good to see you.
Yeah, it's good seeing you. And thank you for this presentation. So I appreciated hearing the model to move away from volume-based care to value-based care. And I just wanted to hear a little bit about how they might integrate the patient complexity when you're looking at patient outcomes.
That's a really good question. And so do you mean in terms of like direct care, or in terms of like billing and reimbursement?
Yeah, I think I was listening to the piece where you were saying like the reimbursement wouldn't be just based on volume, it would be based on the quality of the care. And I was imagining maybe like what you were showing in the registry, like maybe the outcomes. I mean, I don't know what you would be looking at, but like I just imagine like the PHQ-9s and what have you are moving up or what have you. And then I was just wondering, like, how, for the reimbursement, say, how is the patient complexity factored in? Or
Okay.
what's the model for that?
Yeah, that's a really good question. So number one thing that I wanted to make sure I mentioned before we ended today's session is that integrated care has shown to work really well for conditions such as depression and anxiety. There have been now more work on other conditions such as schizophrenia, bipolar disorder, and PTSD. It has shown to also help with certain substance use disorders such as opioid use disorders. However, it is very well established to show that it helps with less severe mental illnesses. And so with that, I wanted to also highlight the fact that this model is not to replace specialty care clinics, because with those specialty care clinics and wraparound services where we have in those clinics, I don't see how integrated care can replace all of that unless you have kind of like a very comprehensive care center with primary care in comprehensive psychiatric and behavioral health conditions. However, in terms of value-based care, from how I understand it, it wouldn't really matter how complex your patient is, as long as you document the complexity of the case and show that you are making improvement and the patient's symptoms are improving, then you would get reimbursed for it, if that makes sense. Yeah, so like I do have patients with PTSD and bipolar disorder, ADHD, and so yeah, it doesn't matter as long as I kind of like I'm documenting all of that and showing that the patient is improving. We can, if we are using a value-based care, then I can get reimbursed for it. But in parentheses, my integrated care is not collaborative care model. Right. Okay, what other questions do you all have?
I guess may I ask another question if there's not others?
Sure.
Do you have any sort of sense or any data on sort of like the satisfaction level of PCPs working in the collaborative care models, psychiatrists or psychologists working in the collaborative care model, sort of like, or other staff members, case managers? Is there sort of sense of like who really likes it, who really benefits from it? You know, do patients like it? Do patients, you know, sort of gravitate? I'm curious, sort of like what the kind of the anecdotal sort of like reports on kind of the model, like what those sound like.
Sure. Yeah, that's a really good question. So in terms of satisfaction, from what I last saw in the literature, it has shown that it improved satisfaction of providers both on the primary care side and the behavioral health care side. And also another thing that was specified in the literature was that it freed up the primary care providers' time to focus on other aspects of their patient's care, where they could rely on the behavioral health provider for like behavioral health and psychiatric care. And then in terms of patient satisfaction, it has shown to improve all different aspects of care, including like access to care, quality of care, things like that. And then one thing that was also highlighted in the literature was specific to stigma. And I've experienced that firsthand from, patients who came in and they were like, it was actually really comforting to come to the same building and sit down in the same lobby where I see my primary care provider without anyone knowing why I'm there. And then some said that it was anxiety provoking for them to go see like a psychiatrist or a psychologist that they have never met before. And the fact that they were going to walk into the same clinical space where they know the physical space and also the staff, and it's kind of like where their primary care is housed, was really comforting to them and helped them overcome that initial anxiety of going to see a psychiatrist. Or a psychologist or other behavioral health providers. Another thing that I've experienced firsthand is that it's very unlikely for patients to fall through cracks for whatever reason, because somebody will catch them. Between me and their primary care providers, if they miss appointments, if things kind of like start going south in their care, one of us will catch that and get them back on track. So that also has been another advantage. Did I answer your question?
Yes, thank you. I guess I was speaking sort of from a perspective of wondering if you know, primary care providers, if maybe they're not familiar with this model and they're used to sort of the original kind of model of, you know, refer out, and sort of feeling like I just want you to take the patient and take care of them, so that I'd fulfill my sort of duty by sort of pressing the button and referring out. And if maybe this sort of more co-located, integrated thing where there's a lot of back and forth, and perhaps, you know, receiving the patient, sending the patient, receiving the patient, you know, maybe runs into a little bit of resistance. So I guess that's where my question was coming from.
Yeah, and that's a real problem and a legitimate concern. So I think what has really helped, and I didn't realize it was going to be helpful in this way in the model that I have here at SRMC, is the fact that it is a combination of integrated and co-located model. And so, and with the co-located piece of it, I'm still in the same physical space as the primary care providers. And so that adds a level of comfort to them. Another thing that I like we did from the get-go was that I had a referral guideline that I kind of ran it by the primary care providers and got it established within kind of like how we were doing business. And so as part of that model, everybody knew that they send me a power chart message to refer patients to me, and then I will send them a power chart message to refer patients back to them. And when I do that in the process, I kind of make sure that they are comfortable with it. There are two other factors, because we have those other components of integrated care in place in terms of e-consults and curbside consults. That helps bring another level of comfort to the primary care providers. So I haven't experienced any resistance in terms of sending their patients back to them. And then they also know that down the road, if needed, they can refer their patients back to me. And that's comforting for both patients and their primary care providers.
Poonè, this is Avi. I just wanted to add my experience with the 10 years of doing SBIRT grants. And so that was a truly integrated model. And Davin, we had peer support workers that were working in primary care, urgent care, trauma, EDs, and they became part of the medical team. And so they had that traditional warm handoff where somebody would knock on their door, introduce them. And so it was much more personal. And they also managed the case referral. And they looped back to the primary care team all the time and said, you know, do you feel that you need more help from our psychologist or a social worker or a counselor? So they knew that that collaboration was totally integrated and totally available. And that personal face-to-face contact, and like Poonè said, the importance of like managing the referral as opposed to just the typical thing is we just give them a phone number. But in this case, we give them a person and a date and an appointment, and especially if it's at the same place where they go for everything else, it's so much. So we're demonstrating that we're integrated as opposed to saying that we're integrated, if that makes any sense.
Absolutely. Yeah, another thing that I experienced was that initially I said I would see patients for 1 appointment and 3 follow-ups. And I ended up, after a few months of trying that, I ended up changing it and seeing patients for as long as they need to. until they are stable and in remission before I refer them back. And then in the process of referring back, I actually taper them off of my services. I start kind of like spacing out their appointments with me to make sure they don't relapse before I refer them. So a lot of different ways that you know, you can play around with different aspects of integration and how it's done to make it work for everyone. I know it's already 2 o'clock.
Yeah, I just I'll point out the comments in the chat by Dr. Nim. Having help on the front end with use of community health workers, like with things like screening, has been shown to help decrease primary care burnout, which is great. And then Dr. Isaacson has been very impressed by UNM family medicine providers who want to be involved in behavioral health care. So yeah, both of our commenters are highly involved in sort of these integrated settings as well. Well, thank you, Dr. Haghani Tehrani, for walking us through that and educating us in integrated behavioral health. Really appreciate you, and thanks everyone for your attention. And hopefully we can have more of this kind of thing here at UNM going forward.
My pleasure. It was an honor. Thank you all for your time. I appreciate it.